Thank you to you all. We are being recorded for joining this breakout group. The conference lineup is incredible. So I know I had some stiff competition for you to land in this Zoom. So I'm excited that this topic was enough to bring you in. You see there in the top blue bar, I'll be using poll EV today. And I see we're up to about 10 participants, which is nice and intimate. So we'll actually maybe also be able to use the chat box and maybe even come off mute and do some talking just together. But if you can go ahead and grab your phone or tablet or whatever device you are not listening to me on, you can go to your web browser. So Chrome, Safari, Internet Explorer, go to pollev.com/Nzinga Harris 835. My last name is Harrison, but character limit wouldn't let me be great. Or you can just use your phone and text Nzinga Harris 835 to 22233. We're going to do some real-time polling and information gathering together. So let's see, we are at 3:02. What we'll be talking about this afternoon for the next 45 minutes is moving beyond biopsychosocial. How do we drive health equity? By providing cultural, politically informed whole persons addictions care. So with that set up, I'm going to go ahead and take us to the first couple of slides, which are just testing our interactive strategies. So I would like to test the chat box. If you can type in the chat box the name of your organization and where you're joining from. I just want to get an idea of who we have in the audience. And I want to make sure the chat box is doing what it is supposed to be doing, which is letting us chat. So I'll ask our tech team. I don't see any answers coming in. Tech team, if you can put, oh, okay. Center for Pan-Asian Community Services, amazing. CPACs from Atlanta, thank you for joining us. Hey, Dominique. NCPC, Dominic from MSM Atlanta. Who else? I know we've got more folks on the line than that. So I just want to make sure you are able to use the chat box as we will use it a bit later in the presentation for some engagement. Wills, good to meet you. Morehouse, NCPC. Ed from SATTC, awesome. Good to have you. All right, so we know the chat box is working. Good to see you, James, awesome. Now let's test this poll EV. Poll EV, so you can see the instructions right up there. You can go to your internet browser. Hey, University of Maryland, Dr. Woodhouse. You can use your internet browser and go to pollev.com/Nzinga Harris 835, or you can text Nzinga Harris 835 to 22333, and then you should see the answer. You should see this question pop up and be able to put in your answer. So if you're texting, you'll just text A, B, C, or D. If you're on the web browser, you'll be able to, touch your finger on A, B, C, or D, or click on A, B, C, or D. And the answers will show up here anonymously and in real time. What is currently your role professionally? Are you a direct care provider? Are you in an administrative role? Are you working a mixed role, direct care and administrative, or something else altogether? We should see the answers pop up here on Poll EV if all is working as designed. Hi, Alicia from Georgia Health Policy Center. Thank you for joining us and for using the chat box. Okay, so everybody so far is working a mixed role, direct care and administrative. Let's see if that, as more answers come in. Okay, other. Tell me what the other is in the chat box, if you don't mind. I want to try to tailor the conversation that we have to who we have in the audience. Looks like we're about half and half on mixed. Oh, okay, more other. Thanks, Mitchell, for sticking that in the chat box for everybody. Those directions are also at the top of the slide. All right, so about a third direct care administrative and about 2/3 doing something else. So as we go through the talk, hopefully you'll feel like it's pointing to exactly what you're doing all day, every day. Usually when I give a presentation like this, my goal is for you to walk out with something you can put to use immediately in your personal or professional life. I have a little bit of a different goal today, which is like, I just want us to think about how we're thinking about innovation and how do we incorporate a cultural political lens into innovating for the people that we're caring for in the healthcare space, whether that's primary care, specialty care, mental health care, substance use disorder care. All right, so we have some administrators in the room, some mixed folks in the room, some other folks in the room. Research and technical assistance. Got it, Alicia. Thank you. Definitely want to think about cultural political lens for research and analytics. So here are our learning objectives for today. Upon completion of this activity, I hope you will be able to apply an innovative thought process to a biopsychosocial cultural political framework as we think about mental health and substance use disorders. I want to make sure we all walk out of here with an understanding of the basic principles of harm reduction. That is just a means to the end. The end is number 3, which is how do we incorporate that understanding of harm reduction into envisioning innovative biopsychosocial cultural political strategies for at-risk populations. So starting with definitions. The purpose of NCPC's conference this year is how do we drive health equity through innovation? And so I want to start with making sure we are using the same concept of health equity and the same concept of innovation. So health equity here, as I would like to talk about it today, I'm going to use the Robert Wood Johnson Foundation. And this is just the first part of their definition because the second part I think is actually quite leading. And I want to keep our thinking open. So on this first part, just from the broadest perspective, health equity means that everyone has a fair and just opportunity to be as healthy as possible. I think sometimes when we think about health equity, we think about access to healthcare. Yes. We think about social drivers of health as barriers. Yes. We think about controlling the symptoms of a chronic medical condition. Yes. All of those are inputs. If we use this broader definition of health equity, everyone has a fair and just opportunity to be as healthy as possible, then we have to ask ourselves, what is fairness? We have to ask ourselves, what is justice, right? We have to ask ourselves, how are we defining an opportunity? And we have to ask ourselves, how are we defining health? And even more importantly, should it be we who are defining health, or should it be the people who are being served giving us their definition of health, and we are building systems to give them a fair and just opportunity to get to that definition of health that they have given us? When we think about innovation, we tend to think about innovation as something completely new that's coming in, toppling over a system, and that's true, but there really are 4 different types of innovations or 4 stages on the continuum of innovation, all of which are equally important. So if you start at the top of this blue circle, there's incremental innovation. That is starting with something we already have, putting new ideas and resources into it to make it better serve its purpose. And the purpose that we're trying to serve is fair and just opportunity to be as healthy as possible. There are sustaining innovations that work to have an intervention that we're making or a system that we've built or a process that we're executing that is doing well. It is serving its purpose, but conditions around that process are changing. So how do we have to innovate on the conditions around that process to sustain the effectiveness of that process, system, intervention to drive a fair and just opportunity for people to be healthy as possible? Then there are disruptive innovations. There are disruptive innovations that are still within the status quo, but aim to topple over the cart. That is, we consider ourselves at Eleanor Health disruptive, right? Like we're coming in, we're trying to change the way people with substance use disorders are treated from an equity, stigma, healthcare services delivery perspective, but also from a healthcare reimbursement perspective. Like we believe fee-for-service drives disparity. it throws up access barriers, it throws up experience barriers. And so if we can get away from fee-for-service to population management, we have a better chance of delivering a fair and just opportunity for people to be as healthy as possible from substance use and other mental health conditions. And then even further than that is the next step, which is radical. We're building on value-based care, which already exists, right? Population health management, which already exists, and applying that in a disruptive way to mental health, behavioral health, substance use disorders. Radical is like, I'm not even starting with what we currently conceive of to be healthcare. I am radically doing something different. And I love this quote from Anashay Wright. She is actually the president of our PTSA at my kid's high school. I'm the treasurer, so I got to work closely with her. She runs an organization called Disruptive Partners, and she's the CEO, her title being Chief Executive Disruptor. She has this quote, "We think beyond boundaries and limitations." I really think all four of these stages of innovation are necessary. All four of these stages require us to think beyond boundaries and limitations. It is a shade of gray how far beyond that boundary and how far beyond those limitations that land you in one of these areas. And so what I want to think about today is beyond the biopsychosocial model, which is a model that we get trained in healthcare, right? In all areas of medicine, regardless of the specialty. And the concept is that illness or health happens at the intersection of a set of biological, psychological, and social factors. So health can develop, there can be a fair and just, access to health as it relates to the biological factors that drive health, the psychological factors that drive health, the social factors that drive health. The same is true on the other side of that coin for illness. If we are trying to enact a set of interventions to drive health or to remove illness, we have to consider the biological, psychological, and social factors that are contributing. And I meant to say at the beginning of this talk, the other way I want you to use the chat box is if you have a thought or a question in real time, stick it in that chat box. I'm keeping my eye on the chat box, and I want this to be more of a dialogue than a lecture using our chat box, using our poll EV, okay? So as it comes to you, stick it in there. I'll see it and we'll have a conversation that way. This is a multidisciplinary approach, can be an interdisciplinary approach. It includes medical professionals, social workers, researchers like Alicia, administrators like those of you on the call working a mixed course, families, communities, governments, whoever you are. The biopsychosocial model says we need you to be part of the consideration for what's driving health or illness, as well as the approach we use to address driving health or driving illness. My premise here for us today is that we have to move beyond the biopsychosocial concept. So biologically, we tend to think of genetic and acquired biological factors. So genetic is coded in your DNA, you're born with it. Acquired, you pick it up somewhere along the way. We know that the bridge between those two is epigenetics, because our life experience and our environment is constantly changing our DNA through epigenetics, and that DNA is being passed to the next generation through reproduction. And so genetic and acquired are joining together through epigenetics. We know that biologically, whether we're treating a mental health condition or a physical health condition, we are one organism, right? And so our brains and bodies are connected through the same nervous system, the same other physiological systems. So there truly is no separation of mental and physical. The way I teach my folks about that at Eleanor Health, to put it in a concrete concept, if I have a person with alcohol use disorder and anxiety disorder and diabetes, all three of those are affecting each other. Diabetes, low blood sugar, feels like anxiety. Anxiety drives a motivation to drink, because drinking treats the anxiety. The drinking, though, is carbs, which drives up the blood sugar, and driving that blood sugar up, it decreases your coping skills, drives that anxiety, increases the drive to drink, right? Like it is inextricable. And so if we're really practicing whole person care from a biological perspective, we have to practice whole person care without these artificial distinctions that we put between physical health, mental health, and even more so substance use disorders. Psychologically, we know that life experiences impact the development of our worldview and how we move through the world. We typically look at that through a lens of adverse childhood experiences. Here's the second time I want you to use the child box. How many of you have, one, heard of positive childhood experiences, and two, understand the impact of positive childhood experiences on health later in life compared to that of ACEs? Have you heard of it? Do you understand the impact? Just hit me in the chat box. Yes, have heard of it. Yes, understand the impact. I think I'm going to make a point here, and we're going to spend some time. We're going to double click into each of these on future slides about innovating the way we think about it. We tend to think about health from a deficit perspective. So Alicia said no. We tend to think about it from a deficit perspective, which is adverse childhood experiences, when we could be empowering ourselves to think about it from an additive perspective, which positive childhood experiences does. So we'll click into that. Socially, we're thinking about what's going on today, right? Like stressors, support system, recovery capital, health capital, right? James said, yes, if these are akin to resiliency factors. So we're going to double click into it. Laura said no. Laura, I think is your last name, said no.
First.
Oh, it was? Okay. My brain somehow knew, even when I saw that. It was just so interesting. This is typically when I talk about pieces, right? It's like, why is this not in the foundational knowledge that we are teaching as we learn how to help people towards fair and just opportunity for health as they defined it? That is the classic like biopsychosocial infrastructure, although positive pieces is usually left out. That's the classic infrastructure. What I want us to do here then is think about the impact of cultural political forces on our biological, psychological, and social health. It is irrefutable. We know that stigma drives illness psychologically, physiologically, even though you shouldn't even let me draw that distinction because physiologically is psychologically and vice versa. We know that racism drives weathering. We know that discrimination in all the forms we have it in this country and world, and marginalization and oppression and criminalization all drive illness. They certainly drive inequities. They certainly remove a fair and just opportunity to health for people. And so if we are not incorporating cultural political thinking into our innovation and design, we are by definition driving inequity, by definition, because the fastest road to inequity is invisibility. So if we're not specifically calling out the impact of stigma, racism, discrimination, marginalization, oppression, criminalization on whatever health condition we're evaluating, on whatever health process we're evaluating, on whatever health system we're designing, even without intention, we are driving inequity. So let's click into biological, psychological, and then we're going to spend most of our time on cultural, political. Biologically, there is this belief that treatment for substance use disorders and other mental health conditions don't work. There is this belief that people with substance use disorders just can't make good decisions. There's a belief that they don't actually want help. There's a belief that if they would just do what we told them to do, things, they wouldn't have active substance use, right? And so I want to click on the biological factors of substance use disorders and point out that substance use disorders perform exactly like every other chronic medical condition we have. So the citation is there. This is actually a Sentinel-McClellan study from 2000 that really started to bring us the data that we needed to drive home this message that substance use disorders are chronic medical conditions. If you look at this, you can see we do a poor job at all chronic medical conditions. Substance use disorders, no different. So that chart on the left is heritability. The closer to 1 your heritability factor is, the more the risk you have for developing that illness is coded in your DNA the day you're born. So 1 is kind of like 100% of it was coded in your DNA. The environment does not influence at all whether you would develop that illness. I don't know any illness that has a heritability coefficient of 1. 0 is there is no biological factor for this illness. Your risk for developing that illness is 100% determined by your environment. I don't know any illness that has a heritability coefficient of 0. When you look at asthma, diabetes, hypertension, our 3 most common chronic medical conditions in this country, you can see between 25% low end of hypertension, and this is essential hypertension, to 70% high end of asthma is coded in the DNA. The heritability coefficient, as measured by twin studies, is in your DNA the day you're born. The other way you can think about that is like, okay, so between 30% and 75% of your risk for developing asthma, diabetes, hypertension has to do with your environment, those early life experiences, and those ongoing psychosocial, cultural, political factors. Look at addiction, 34 to 61%. So just looking at this chart, is addiction more or less inherited than hypertension? Hit me in the chat box. Is addiction more or less inherited than hypertension? More of your risk for developing addiction is coded in your DNA the day you're born. And yet we say to people, poor choices. Even if we don't say it as a culture broadly, we believe it, right? That is looking at it from a deficit perspective. Looking at it from an empowering perspective is like, okay, if 61% of my risk for developing addiction is coded in my DNA, I got 39% that I need to work on this environment to try to mitigate that risk. When we look over at this chart over on the right, this is like, okay, people who are admitted to the hospital for the condition under the illness column, 1 year later, had they experienced a relapse of that illness, and were they following the treatment recommendations made by the inpatient team? Now, this is back in 2000, before we had meds for addiction other than methadone, and it's not a methadone study. So that's why you don't see meds and lifestyle broken out there, because there were only lifestyle interventions to be made back in 2000. 40 to 60% of people with addiction were following treatment recommendations at a year. 40 to 60% of people had experienced a relapse of their substance use disorder. I use my language very carefully there, because what we say is the person relapsed. The person does not relapse, an illness relapses, right? Like if we're using medical language, when you have a period of symptoms, when those symptoms go away, you're in a period of remission. When those symptoms recur, that illness has relapsed. Think about it with breast cancer. You don't say a woman with breast cancer relapsed. You say her breast cancer relapsed, or her breast cancer came back. Extremely important. This is a cultural, political point that I'm making, which is how we stigmatize substance use disorders with our language. But look at this. 40, 60% of people following treatment recommendations, 40, 60% have a relapse of their illness at 1 year. Asthma, less than 40% following medication recommendations, less than 30% following lifestyle recommendations. So people with asthma also don't want to get better. 60% of people with asthma have experienced a relapse of their illness 1 year after hospitalization. So treatment for asthma does not work either. No more inhalers, right? It sounds crazy when I say it about asthma, but this is the system we have built for addiction. Diabetes, less than 60% following medication recommendations, less than 30% following lifestyle recommendations. 30 to 50% have experienced a relapse of their diabetes, meaning their blood sugar is uncontrolled at 1 year. Treatment for diabetes don't work. No more insulin, no more glucophage, right? It doesn't make sense, but when you think of it cultural politically, that's the environment that folks are receiving substance use disorder care, and it removes the motivation to ask the question on the next slide, which is, what is it about the recommendations we're making that makes them so hard to follow? This is a turn on the way we think about it, which is patients don't follow our recommendations, or you don't want to get better, or treatment of that illness doesn't work, when maybe It's something about the recommendations we're making that makes them so hard to follow. So we're a small group. We have 15 people on the line. Whoops, I didn't mean to go forward. So from an innovation perspective, right, as you ask this question, innovation is always starting with asking the question differently than the way we have been thinking about an answer to a problem. How can I ask the question differently? So anybody want to put in the chat box or take yourself off mute? Like, have any ideas about what it is about the recommendations? Because if you look at this, the recommendations we're making for all of these most common chronic medical conditions cannot be followed. It'd be different if it was one person that didn't follow and would be like, you know what, the recommendations are fine because you're the only person that can't follow them. So let's figure out what's going on with you. This is 70% of people cannot follow our recommendations, leading to 40 to 70% relapse rate at 1 year on all of our chronic medical conditions. What is it? What is it about our recommendations? Any ideas? I'm not asking for solutions. I'm just asking for any thoughts you have on what it is about our recommendations. This is how we start innovating, right? We rely too heavily on information rather than relation. Okay, James. Info just provides the opportunity to do things differently. Agree. Relationship, this is my personal and professional belief, and this is how we've built Eleanor Health also. Relationships drive health or drive illness. Without relationship, there is no opportunity, right? So I like that, it relying too heavily on information rather than relation. So then you take that hypothesis and you say, okay, then either in an incremental, sustainable, disruptive, or radical way, how do I think about a solution for health that starts with relation rather than information? And that's where innovation towards equity starts. If I can give fair and just access to relation, then I can drive fair and just access to health. That's a hypothesis that starts the beginning of an innovative cycle. They're all too much of a one box fits all mentality. Absolutely, right? We try, medicine is and health is all about standardization. It's about standardization and the evidence base so that you can have the evidence that this intervention works this amount of the time so that you can give people informed consent on benefits and risk analysis so that you can scale a business. I'm at Eleanor right now trying to figure out how to scale an individualized model so that we can provide it to as many people as possible. Lack of individualization drives inequity because guess what? This person doesn't need what this person needs, and this person has a different definition of health than this person. So then how do you take the hypothesis that one box fits all mentality is driving inequity and injustice and illness? How do you then start to think about in an incremental, sustainable, disruptive, or radical way to approach healthcare from a one box fits one perspective instead of a one box fits all perspective? With addiction, it doesn't factor in recovery capital. All day, Ed, right? All day. And even recovery capital, which we measure, we quantify recovery capital into data at Eleanor Health and use that to drive our interventions and measure the impact that we are making for people. Guess what? Everybody, we use recovery capital scale and measures 35 different social drivers of health. We can look at our population level and say, these are the most common social drivers of health. These are the interventions that are driving improvement in that. That's how it's helping people get closer to their concept of health. At a population level, that helps us design the care model. At an individual level, it goes back to what James said, which is how does that recovery capital relate to this individual person's definition of health, to bring in Mudasim's idea, and how does that lead us to design an intervention for that person that gives them fair and equitable access to their definition of health. So you see how asking the question differently brought us 3 different pathways to innovation towards driving equity. So psychologically, thank y'all for y'all's interaction. It's so much better than when I'm just like standing here like, because 2 brains is better than 1 and more brains are better than 2, right? Exponentially. Looking at psychologically, here's my point. I said earlier, don't y'all let me say psychologically and physically or psychologically and physiologically, because it is all the same stew. We are one organism. What we know about ACEs is that 61.5% of adults in the US, 48% of children by the age of 18 have been exposed to ACEs. This is everybody. This is more than 1 and 2, right? So ACEs are the rule, not the exception. These are the 10 ACEs and the blue boxes over to the left. What we know is that ACEs score greater than 4 predicts in later adulthood, obesity, diabetes, depression, suicidal thoughts, STIs, heart disease, cancer, stroke, COPD, broken bones. We tend to think of ACEs as predicting substance use disorders and mental health conditions, which is true. The relationship is undeniable. Increased risk for smoking, IV drug use, alcohol use disorder. It is true. My point here is that separating that out from our other chronic health conditions is a losing proposition. That person is walking in the door to you as one person with a set of experiences, cultural, politically, socially, psychologically, and biologically, that are leading to the health picture we have today. And so how do we take the knowledge of those ACEs, the knowledge of the risk it confers, but how do we move to pieces? If we're trying to practice generational prevention, then yes, like, did I sit down with my husband and teach him about the ACEs and say, we need to do our best to keep our kids' ACEs score as close to 0 as possible? I sat down with my husband when our first child was born. My kids are 15 and 16 now. And I was like, we have to get it as close to 0 as possible. And then I made a joke. So you see parental separation and divorce, this means I need you to act right, right? But like, very seriously, we were very systematic. We're going to try to keep our kids' ACEs score as close to 0 as possible. What we also need to be doing as part of generational prevention, because we know, like, my family history is stacked. My family history is stacked for cocaine use disorder, alcohol use disorder, schizophrenia, depression, ADHD. I'm bringing all that in my DNA, right? Like, we're definitely on the 0.61 side for heritability coefficient for substance use disorder. So we have to be completely proactive about that other 39% for our kids. That equals not only just avoiding ACEs, but intentionally exposing the kids to pieces, right? Positive childhood experiences. So here are the 7 positive childhood experiences over on the left. Did you feel able to talk about your feelings to your family? Did you feel your family stood by you during difficult times? Did you participate in community traditions? Did you feel a sense of belonging? Did you have friends that supported you? Did you have at least 2 adults who were not your parents who took a genuine interest in you? Did you feel safe and protected by an adult in your home, no matter who that adult is? And so this is not asking for an absence of ACEs. You could have an adult in your home that is being abusive. But if you felt safe and protected by another adult in your home, that mitigates the risk of those ACEs. So check out this study over on the right that found the number of pieces mitigated the risk no matter how many ACEs you had. So for people that had 6 ACEs, if they had 0 to 2 pieces, their odds of depression and poor mental health in adulthood were lower. 3 to 5 pieces, 50% lower. 6 to 7 pieces, 72% lower, statistically significant. If you had 8 ACEs, yes, your risk for developing those chronic conditions is higher than somebody that had 4, but it's lower than somebody that had 8 ACEs and 0 pieces. if you had 8 aces and 6 to 7 pieces. So we may not have complete and utter control over keeping these aces to 0 from an individual perspective, from a family perspective, from a community perspective. We can be building community to drive these pieces for our kids. And the other piece that is extremely important is that these pieces exert extreme mitigation of the aces when they are present in childhood. Even for our adults who didn't get them in childhood, if we can focus on these pieces for them, even in adulthood, it will mitigate the effect of the aces they have experienced throughout their lives. And so here's another opportunity for innovation from a cultural political perspective. Remember, cultural political is racism, oppression, marginalization, criminalization, being invisibilized, right? Being discriminated against. Why have so many of us heard of ACEs? We know ACEs inside and out. We know the impact of ACEs, but we have not been empowered with pieces. Why do you think? Part of it is from a cultural political perspective. We don't think our communities, one, we don't think of our communities from a positive lens. Two, we don't think those positive aspects are available in our communities. Three, we don't believe we can get these positive experience to children on a mass scale. So from an innovative perspective, when we ask the question, why, we come to a hypothesis. What do you think? Hit me in the chat box. Why do you think so many of us know about the rates of ACEs in communities that are poor, in communities of color, in immigrant communities, but we don't know about the pieces? Why are we not systemically designing for access to pieces? Instead, we're designing against ACEs. Our systems are deficit-based where reimbursement is concerned. Nothing curative in the DSM. Okay, James, you're gonna take me to church, right? From a prevention standpoint, more difficult to prove what did or did not occur. So we got Alicia doing data and research, right? We got James hitting us with the truth in this chat box. How do we, from an innovation perspective, incremental, sustaining, disruptive, radically, how do we start thinking about health, not from a deficit perspective? Like, I don't even have a term. What's the opposite? Can y'all give me a term for what the opposite of deficit perspective in healthcare design would be? The fact that I don't even have a term in my brain right now to succinctly describe that means we're in need of innovation. It means we're in need of innovation, because I should have a term. If deficit-based is a term, I should have what this term is at my fingertips, right? That is an opportunity to think differently from a cultural political perspective about what we can be doing differently. Strength and resilience. Yep, absolutely. Strengths-based, resilience-based. I absolutely think it's a generational thing. And I think the more generations, the more we program generations to deficit-based, that's like epigenetics, right? The more it's going to accumulate. So how do we start programming away from deficit-based, the same way this current generation is programming away from racism-based, away from oppression-based, away from marginalization-based? So we only have 6 minutes left. So I want to really double click on this concept of racism as trauma. Racism is a chronic, cumulative, ongoing trauma in the lives of Black people, other people as well in the United States. When we have these big events where we see people get killed in front of us, those are acute on chronic traumas. I want you, this slide is difficult. I want you to just sit with it. And I want you to take note of the thoughts you have, the physical sensations you feel in your body, the emotional sensations you feel in your body. And then we're going to use Poll EV kind of to just let us share what those are. Don't try to assign value. Don't try to figure out what it means. Like, just take note of it. What did you feel? What did you think? What physical sensations came up? Numb. Wow. Despair, sadness, anger, weakness, hopelessness, hate, overwhelmed, never ending, sadness, overwhelmed. It's a cycle. So many killed, never ending. What physical sensations are you noting in your body right now? Shortness of breath, tightness in your chest, right? This is a trauma reaction. So if I had to convince anybody on this call that racism is trauma, here are the 3 E's of trauma: a series of events that are experienced as physically or emotionally harmful with lasting adverse effects on mental, physical, social, emotional, or spiritual well-being. Racism and oppression are trauma. They are a series of events experienced day in and day out that are physically and emotionally harmful and have lasting effects on our health. And so here's an incremental or sustaining innovation. Trauma-informed care is already an infrastructure that we have. If we equip people to provide racism-informed care, just everywhere you see the word trauma, put in racism, you have an entire infrastructure that you can use to start culturally, politically innovating towards fair and just access to health for people. The 4 R's say we have to realize that the impact of race-based trauma is the rule, not the exception. We have to recognize what that looks like. We have to be prepared to respond to that. And we have to design systems that resist re-traumatizing. So everyone of color has been race traumatized at work. If you have been a patient in a health system, you have been race traumatized in the health system. How do we get the healthcare system to take on the responsibility for racism-informed care the way we have taken on the responsibility for trauma-based care? These are the 5 principles of trauma-informed care. I'm just bringing it home, like we have a whole infrastructure that we can innovate against already. That last one being empowerment. Probably should be first. Like trauma-informed care tells us we have to do all of things. Empowerment. We frequently leave out empowerment. So I know we're at 3:45, which is the end of our time. We didn't get to harm reduction. I'm fine with it, right? Like my goal was for us to come out of here with a cultural political perspective centered towards our ability to think beyond current boundaries and systems to innovation. And this, I'm happy to leave us with our last question here and then open it up for dialogue for a couple of minutes. How do we empower our communities to design and implement race-based trauma-informed systems for themselves? So I'm going to stop talking. If anyone, I'll open it up here for questions, comments, thoughts. I do want to get, oh, that's my family. This is the reason I do this work. You can see my 2 boys there, 15 and 16, left to right, my husband in the middle. I do want to just leave this up here and you can put them in if we'll take 5 more minutes or 2 more minutes. Anyone want to come off mute, want to type any ideas in the chat box? want to add any ideas to the poll, Evie? I hope this time together was successful at just forcing us to broaden our concept beyond biopsychosocial. Ask, listen. Number one, number two. That's actually innovation for healthcare. We ask, but we don't listen. Awesome. Well, in the interest of time, I'm going to stop sharing my screen and just say, echo the Morehouse message there. Thank you for joining this session. Thank you, James, for the positive reinforcement. I hope you will take this with you, go out into your professional and personal lives and innovate. With that, that concludes this breakout session.